Welcome to Safety Spectrum, your environmental health and safety connection. This program is a presentation of the Michigan Safety Conference. For almost a century, the annual conference has provided credible educational opportunities and valuable support to the safety and health practitioner by offering 120 instructional programs along with exhibits highlighting the latest in safety equipment, instrumentation, and demonstrations. To learn more about the conference, please find us at safetyconference.org. Welcome to Safety Spectrum. I'm your host, Sheila Ide. This program is sponsored by the Michigan Safety Conference, and our topic today is SAFER, Situational Awareness for Emergency Responders. Where are our safe places? In today's somewhat volatile society, emergency responders face an increasingly aggressive public while performing their duties in healthcare. Their own safety can be threatened while in the very act of rendering aid to their patients. Our speakers today will discuss their program at the University of Michigan Hospital. Michelle Stanley is the Educational Nurse Coordinator in the Psychiatric Emergency Room at the University of Michigan Hospital. Her 20 years of nursing experience include neurology, neurosurgery, the neurointensive care unit, child and adolescent psychiatry, and adult and child psychiatric emergency services. Michelle is also involved in numerous committees and Michigan Medicine hospital-based initiatives. She has participated in the Evidence-Based Nursing Fellowship Program and is chair of the Nursing Unit-Based Committee. She received the Nursing Excellence Award at Michigan Medicine and Innovation and Research. Michelle received her BA in nursing from the University of Michigan School of Nursing and is a mental health board-certified psychiatric and mental health nurse. Our second speaker is Brian Uridge. Currently, he serves as the Senior Director at the University of Michigan Department of Public Safety and Security and oversees Michigan Medicine Safety and Security. He is a sworn police officer for the university. Brian manages over 225 public safety staff members for a system with 40,000 employees that see over 4 million patients a year. Brian retired as the Assistant Chief of the Kalamazoo Department of Public Safety in Kalamazoo, Michigan, after 23 years. He is the recipient of the Kalamazoo Public Safety Medal of Valor and Kalamazoo Public Safety Life-Saving Award. Brian holds a bachelor's degree in criminal justice and a master's in public administration. And he's also a graduate of the FBI National Academy and holds board certifications as a protection professional, healthcare protection administrator, and threat manager. Thank you for joining me today on Safety Spectrum.
Thank you.
Thank you.
Well, I'd like to take a moment to just ask each of you to talk about your duties. So I think it's kind of self-explanatory, but what would you like to share with us? Michelle?
Well, I'm the Educational Nurse Coordinator at Michigan Medicine in the Psychiatric Emergency Room. I've been at the University of Michigan for 20 years. I've been in this department for 9. And I've recently been published in 2 journals. One was with Brian Uridge, who's the other guest today. And more recently, I was published in the Journal of Autism and Neurodevelopmental Disorders.
And those are your areas that you're especially interested in from your background?
That is correct, yes.
And Brian, you want to talk a little bit about what you do at University of Michigan? You've got the whole university, right?
I do. And first and foremost, if I had half of Michelle's energy, I'd be, I tell you what, she does a lot. So she's the one that makes all this happen. So ultimately, the best way to explain what I do is I work to make sure that our patients, staff, and visitors are safe. But just as importantly, we work to make sure that they feel safe. And by doing that, our focus is to really focus on 3 pillars of what we call healthcare safety and security. That is building trust, training, and technology, and bringing those 3 pillars together to make sure that people are safe. And today, what we're talking about with our SAFER program that we've worked to develop is really that second pillar, which focuses on training. So that's really what I do.
Okay, appreciate that. Michelle, could you please describe the SAFER Situational Awareness for Emergency Responders program that Security Director Uridge and the nursing staff created at Michigan Medicine?
Sure. And I'd like to talk about how it came about. So each year, each department at Michigan Medicine has to take an employee engagement survey So it surveys staff on the climate and what could we do better. And in May of 2022, 82% of our nurses responded that they didn't feel safe caring for patients with aggression. And so as a result of that survey, we have to form action plans. And so what we did was we heard the voice of the staff, we interviewed the staff, and we asked them, like, what situations are making you feel uncomfortable with aggressive patients? And then nursing combined with security to come up with this SAFER training program. So SAFER stands for Situational Awareness for Emergency Responders. So it took us more than 6 months to create this program, and we kicked it off in January of 2023. And what it consisted of was we had a 1-hour didactic session where we learned about proxemics. We learned some of those police-based strategies that nursing doesn't have awareness of. We also incorporated some of our big box training, which is called WELL. So we kind of used that. And then after the didactic session, we did 3 interactive scenarios. So these are hands-on scenarios, and they lasted 20 minutes each. So those scenarios came out of what the nurses, those situations that the nurses said that they felt unsafe in. So we actually recreated those scenarios for them. And one of the most interesting things that we did is we actually watched video footage of previous violent events in PES. So in the psychiatric emergency room, we're always being recorded. And so we watched some of the videos of us actually being assaulted, and we critiqued those videos. So for example, in one of the videos, I actually get punched in the face by a patient. And so we went, ran the videos by legal. We blurred out the faces of the people in the waiting room and the patients. And we were able to critique what we did. And it was very engaging. The staff really appreciated it.
Was this an actual incident that you were, or was it play acting?
No, it was a true incident that was caught on video.
Wow.
And so we were able to critique these incidents. For example, I got too close to a patient that was on a stretcher, and the patient punched me in the face. And so we were able to critique what we had learned in the didactic portion of the training. So we talked about, like Brian Uridge talked about, having that reactionary gap, like always approaching patients from a distance so you can assess them. So we went over techniques like that. And it was really powerful and engaging for the participants because they were part of those videos.
Yeah, I've got over 40 years in the safety business, and security always walks hand in hand with it. And even in personnel, you have so many upset people that don't get, I mean, this is before the way things are now. People just getting upset they weren't interviewed, couldn't see someone, And it was interesting. I had to come up with ideas to create barriers. I mean, we just even think that way 10 years ago, even.
Right.
So it's kind of interesting. So what was the purpose of the training programs outside of alleviating some of the stress?
Well, the purpose was to teach staff more than just our big box training, which is a great de-escalation training program. But we wanted to teach them more because they said that they didn't feel safe with caring for patients with aggression. So one of the things we wanted to do was to increase their confidence of caring for patients with aggression. So we actually used a validated tool called the Clinician Confidence in Coping with Patient Aggression tool. And this is a scientific tool, and we measured staff pre and post training. And so it's statistically significant that they actually felt more confident after the training, and that learning did occur. So that's pretty amazing. So we're actually publishing a journal article around this data.
We're probably going to talk about this throughout the program, but you have ways of reporting. Do people make reports of situations they didn't anticipate, or is there some kind of reporting system?
There is a reporting system. Brian, Uridge might have more.
Yeah, there's at Michigan Medicine, there, like many hospitals, there are multiple different ways that people can report when they've been a victim of some level of violence. So many of those come through obviously the DPSS website, or they'll call our dispatch center and they'll report it and we'll take a report. Or there's other compliance reporting methods, multiple different ways that the same nurse can report, I have been a victim of violence. And we want that because we want people to be able to quickly show that they've been a victim of violence, and how can we follow up with training? How can we follow up to make sure that the nurses feel supported?
Now, I asked this question of both of you, put you on the spot a little bit. Do you really think the amount of aggression, violence has increased over the years? You both had many years in the business, so what's your take on it?
So statistically, we know that between 2011 and 2019, there was a 63% increase in violence in healthcare. Now, that is before COVID numbers. We also know that only 30% of physicians who are physically assaulted and only 26% of nurses who are physically assaulted ever report it. So we then know the numbers are the actual numbers are very, very low for people who report it. And then a few more stats, and Michelle always makes fun of me because I'm a stat person. So the average injury rate for any job in the United States is for workplace violence is 12 incidents per 1,000, 12 incidents per 1,000. Well, nurses are at 22 to 34 incidents per 1,000. So that's over double the rate. But then when you dig deeper into the psychiatric areas, we know that psychiatric techs have 68 injuries per 1,000. So much more than the 12 incidents of the regular public. So those are significant stats, which really brings home the need for what we did, where we combined, three simple principles: situational awareness, proxemics, and de-escalation, and then using that scenario-based training to help drive those learning points home.
What's your feeling on that, Michelle? You feel that increase as well?
I feel the increase personally when I staff, and I see it, and we do have data for our department specifically that the rate of violence is the highest in Michigan medicine in our entire institution. But what's interesting with the SAFER program, in May of 2022, the violence towards nurses, we had 11.8% rate of like patients attacking us. And then 9 months post SAFER training, we gathered data that the rate of violence towards nurses was 6.4%. So this represented a 46% reduction in violence towards nurses. And so we were able to actually share that information at the Magnet Conference, which is a big nursing conference that was held last October.
Okay, that's great. I think MIOSHA has always had healthcare as one of the emphasis programs that they focus in on because they're aware of the stats as well. What were the outcomes of the training program outside of the stats that you just gave me?
So definitely staff felt more comfortable with caring for patients with aggression. So we had that, and we used that validated tool to actually assess people. So it's statistically significant. And so staff feel safer overall. And then going with that, we have that reduction in violence towards nurses at least 9 months after SAFER. That's the data that we collected.
I don't know if this is even a fair question, but I know a lot of mental health institutions got closed down over the years, and it does seem like there's more people in the streets that are struggling with alcohol, drug abuse, that sort of thing. They don't have any place to go. So do you think that adds to the problem?
I think that does add to the problem. And then where we are, it's very unique because we can have patients come in that are on drugs. So maybe they're very high in cocaine, or they're just kind of out of their minds from doing drugs. So we can have those patients that come in really hot, oftentimes with the police, And so sometimes I think that's why we are seeing that higher rate of violence. That's a good point, is that homeless population and substance abuse
Yeah.
population.
When I was working for the city, I had the opportunity to ride with the police officers at times, and it was amazing the number of times we were having to basically shake down people who were wandering the streets, and whether
Yeah,
they were a threat or what have you. And usually they were frequent flyers, as they called them, people they knew. And once they hit the streets again, they were right out there to checking them out. What are you doing?
that's a good point.
So I think we'll switch to Brian a little bit. How did you design the situational awareness and proxemics content?
Well, the first thing we did, and that's a great question. Obviously, this was just an incredible partnership between clinical staff and DPSS members where we use security and law enforcement. And the first thing we did were we were able to get permission from our legal department to use 5 very specific videos that were our clinical staff being assaulted or security staff being assaulted. We were able to fog any identifiers out so that we respected the patient privacy, the rest of the people in the waiting rooms and things like that. And that first and foremost was so powerful because people were able to see their workspace and their incidents and see people that they know that they're working with. Very, very incredible. So that was great. And then when we started to design the scenarios, there are simple things in law enforcement, for example, where we are talking to someone and Michelle and I will be using something called contact cover, which is if I'm going to be the one that's talking to you, Sheila, and trying to de-escalate you, Michelle is going to be to my right or to my left, and she's going to be what we call the cover officer. Now, we actually had nurses go through these actual steps and role play those out on what that looks like, how to make sure that I have a reactionary gap, how to make sure that my body's positioned properly, how do I make sure that if you're right or left-handed so I can move to your non-dominant side. And all of those steps help make sure that our staff felt empowered when they were dealing with situations later on. And then one of the qualitative things I think that really came out of this was the partnerships that we were able to develop with our social work partners, and that they realized that during a critical incident, during a patient violent event, that they could take an active role in helping other people in the waiting room. There were things that they could do to help improve the patient experience while Michelle and her staff were dealing with an escalating patient. So many, many benefits to this.
Is it unusual to have the nursing staff working right with the security staff and developing this training? It sounds like it sounds logical, but maybe it's revolutionary too.
You know what? It is like you're right. It is logical, and I would say this is we have a very close working relationship with PES only because they obviously are in a very violent area of our hospital, and we want to make sure that we keep people safe. And this was just an excellent opportunity to really understand what each other are dealing with, build those partnerships. And we might have not covered this earlier, but one of the other benefits, Sheila, is that we actually trained our security staff at the same time we were training nursing, physicians, and medical assistants and social workers. And right there, you build a natural relationship. Right there, you build a friendship. And so that carries forward months down the road as you're dealing with other situations.
I was going to ask that. It's funny that you said that because one of the things is often a police officer comes in contact with somebody who is actually mentally ill, and they're not social workers, so it's very difficult for them to play both sides. So hopefully this has helped some of that you can call on somebody, or they know they can call on somebody.
It really has. It's really gone viral. We've had so many requests throughout the rest of the health system to actually do something similar in their workspace, a similar concept of safer, just in their specific workspace, which is really great.
So do they actually practice the techniques? Do you do some role playing, that sort of thing?
We did during the training, and then I don't know what Michelle, if you want to comment on the follow-up there.
Well, for other institutions, I think people are trying to individualize it. But there is a lot of interest, I would say, across the country. So I just got back from the National Update on Behavioral Health Emergency Conference, And there are many physicians who have psychiatric emergency rooms that want to adopt this SAFER training program. We've had quite a few inquiries where they want to know the details of the training because they do want to replicate it and be able to do some of the hands-on portion as well as the video portions of their own.
And I don't want to put anybody on the spot, but was there any resistance from either side of doing this training, the safety officers or the nursing staff? They were just looking for help, basically.
I would say no. I think we were very lucky that Dr. Hong, who runs the area, he was such a proponent of the training. He really took a leadership role and was present at the start of every single session and was there at the end of every single session to get staff feedback on what can we do better for the next training. So when you have that type of leadership engagement, I think it can only be a win.
That's good. So where do we go from here with the training?
So for sustainability, at least in my department, what we're doing is we're tacking on this SAFER training at the end of our WELL training, which is our big box de-escalation program. And so we want to sustain the learning that has occurred. There has been talk recently about doing the SAFER program again, because with nursing, we don't have a lot of turnover, but with social work, we do. And so we want to catch these new employees that are coming through because the data doesn't lie, right? We know that the incidences of violence towards nurses has decreased. We know that people are more confident in caring for aggressive patients. So we are talking about doing another round of SAFER, but also sustaining it, at least in nursing, by teaching it at the end of WELL.
I think you mentioned some statistics that showed that you had less incidents or you had better handling of the incidents since the training.
So less violence towards nurses. So a 46% reduction in violence towards nurses.
What do you attribute that to? Just the way they're approaching the person, or?
I would think so, yeah, because a lot of nurses like to approach patients and get close because they feel like that's compassionate care. Like if I touch your shoulder or I come close to you, I care more for you. But we're teaching nurses, you can be compassionate from a distance. You don't have to get close. We can make that reactionary gap. We can assess the patient. And again, things nurses never knew. Like I never knew about contact cover. I never really thought, I have an aggressive patient in a room. I'm just going into the room. I never thought, well, let me have security go first. And then there's someone behind security. So you have so we're learning new things and new really police-based tactics that we're not aware of. And so I do think that has been a big help.
I'm sure it's hard for some of the nurses, longtime nurses, to have to use these kind of techniques when, like you said, they're used to compassionate care. And now they have to treat everyone like they're a potential threat. I think that's kind of what you're saying. That's unfortunate.
Well, I think there's compassion that's still there, but there's more situational awareness. So scanning the environment, assessing a patient. It's okay to get close to patients, but you have to assess the situation. And so I think that's what we're training them to do. And really the feedback from nurses was absolutely phenomenal. I mean, it was positive. Every department has just a handful of like naysayers. But even those people were just raving about the program. So I think it's really impactful.
Yeah, and that is truly the benefit. You can still provide compassionate care. You can still use trauma-informed care techniques. You can still be empathetic, all while making sure that you have a reactionary gap, that you've walked through the doorway the appropriate way, that you've identified whether the door opens in or out. There's all sorts of subtle things we can do to keep our staff safe and compassionate at the same time.
I could have used some of these techniques. Like I said, many years ago when I did a stint as a personnel director, I had to deal with, some would say, difficult employees. So-and-so packs a gun and he comes to work, and you talk to him about it. I go, okay, how do we handle that one? So I came up with a deal. All right, somebody stands outside the door. I say file 11. You call the police over. or, positioning myself so I can get out quickly, that type of thing. Having someone with you. I mean, a lot of times it's confidential in personnel, so you can't always have witnesses, that type of thing. So yeah, some of these techniques would have really helped us out. So I think you're already getting questions about this from other hospitals and healthcare facilities. So how adaptable are these techniques?
Very adaptable. In fact, one of the things we say during the training is, remember, these techniques they can work if you are working with a patient's family. They can work if you're dealing with an angry staff member. All of those things work. For example, Sheila, we teach the clinical staff, if you're dealing with a family member or an employee or whatever that is, make sure that the chair that you're in has wheels, and make sure that the chair that the person's in does not have wheels, because we know action's faster than reaction. So therefore, you need to give yourself all the advantages you can. And if your chair does not have wheels, it will take you an extra second to push backwards. Whereas if my chair has wheels, I've now just given myself a little bit of an edge. And those are the types of things that we taught the staff to use. And those are really applicable to any environment.
That's true. We talk about situational awareness. That's exactly what it is. Look at your surroundings. Don't just walk blindly into the without realizing what's around you. I hate to say it, escape routes. I mean, I can't sit in a restaurant without facing the door. I mean, it's just built into me. I got to know what's going on. So, was there any impact to a diverse workforce in implementing this program? I think you were talking about you use multiple disciplines and multiple inputs.
Yeah, so we trained with security, social work, medical assistants, physicians, and nurses. So there were tons of different disciplines involved. And I think that it helped everyone. And again, it's those police-based tactics that nursing had no knowledge of. And a great example is, Brian taught us about confirmation touches. Like, we put our cell phones in our pocket and we touch our pocket, but we never consciously are thinking about this. And then shortly, after learning about that, we had a patient walking around in our department that kept patting their leg. And someone noticed, that's a confirmation touch. And that patient pulled out a fully intact syringe. And so these little things and these little skills, I think they went across all disciplines. Social work has like their own little area where they sit in a room and they're doing a lot of work, but they never interacted much with nursing. Well, after this training, we identified that was something we could improve on. So now when we have a behavioral health emergency, social work comes rushing out. Social work gets involved. And this was solely related to the SAFER training, because at the end of the training, we did a big debrief. And this was one of the big things that came out, was that, hey, we need all hands on deck when we get a behavioral health emergency. And so we actually started tracking data with that as well. That might be a different podcast. But we call that behavioral health emergency. And every time it happens, now we fill out a worksheet, and on the worksheet, we go over, was a doctor involved? Was a social worker involved? And we're keeping track of that data, and it has made a huge improvement.
So it's a living document, so to speak. You're kind of reviewing things as you go, and it's not like a
That's
yearly
correct.
thing. It's like as you go, you're changing the document or the way you train.
Yes, after every behavioral health emergency, we
Either
are
one of
following
you,
it up.
what would you suggest for somebody wanting to implement a program like this?
I think it's replicable. We are writing a journal article that will probably be published in the next 2 to 3 months. So we are advising people to check out that journal article, because it'll have a lot of the details in it.
Any thoughts, Brian?
Yeah, I said first and foremost, the key is you've got to sit down with a multidisciplinary group and determine how can we work together? What is the ultimate goal here? And the goal is what? We want to make sure our staff are safe, but we have to make sure that they feel safe. And if that's our goal, how can the different disciplines work together to make sure that happens? Instead of looking at it from just my lens, which may be a law enforcement or a security lens, Michelle's going to look at things a little bit differently. whereas a social worker may look at things differently and get a physician involved as well. That's really the true success, is the collaboration that we had right from the beginning, right through the development and the delivery of the training.
I think that's so key that you have the different disciplines represented equally, because there's not always one way to do something. So that's terrific. I know this is kind of an odd question, but why do you think this topic is so important?
Well, I would say, I mean, obviously the stats back in 2019, OSHA came out and showed that 72% of all violence in any workplace occurs in a healthcare setting. 72% in any workplace. So we know that our clinical staff, specifically nurses, are in a high risk profession. And knowing that, if we dive down into it even further, we know that psychiatric areas have the highest risk, and in emergency rooms in general account for 41% of all violence throughout the healthcare. So we know where the issues are. Now our job is to develop training to hopefully reduce those violent incidents and reduce the injuries that our staff are receiving.
Makes sense. Kind of closing up now. If we got any final thoughts, either one of you? Just reiterating what we've been talking about and how important it is to have some kind of training in place. Sounds like.
But the only thing I would say is if any of the listeners want this, feel free to get a hold of us. We will gladly meet with you, give you, I always tell people, we'll give you all the content. We'll give you the slides. We just give it away. If it means one nurse is safer because of this training, then that's better than a paycheck. So please get with us and we will give you all the information anytime.
And I'll put a plug in for the safety conference. That's kind of our way of doing things too. We get to network with people that are in the same business, and we are very happy to share whatever we have learned. Absolutely. And safety, security, environmental, all of that. You don't have to reinvent the wheel every day, right?
Well, and I think Michelle and I aren't we speaking at the safety conference, Michelle?
Yes, you are.
Okay.
Yeah, absolutely.
I was looking at my schedule. I think we are.
Yeah, I want to introduce you. So our mission with the Michigan Safety Conference is to enhance workplace health and safety by sharing EHS best practices, provide education, and create a community of experts to help eliminate workplace injuries and fatalities. Hospital personnel face frequent threats from unwell and unruly patients and their families. The SAFER program offers some insights to help address those threats. Thanks to Michelle Stanley and Brian Uridge from Michigan Medical for sharing their thoughts and experiences and introducing us to their program on situational awareness. And like you say, it's a bonus. Brian and Michelle will be speaking at the Michigan Safety Conference, April 15th and 16th. So if you have any questions about this podcast, would like to register for the safety conference in Lansing, or if you would like to be a guest or sponsor one of our podcasts, you can check everything out on our website at michsafetyconference.org. Thank you for listening to Safety Spectrum. This is Sheila Ide.